Hey everyone, so I wanted to finish off Unit 8, which is our Male Reproductive Disorders. We last left off at acquired disorders, and one of our acquired disorders is going to be urethral strictures. This is essentially a narrowing in the urethra, and this can be caused by scarring or trauma. When we think about risk factors, we got to think about anything that can cause scarring or trauma in the ureters. That will be a risk factor. So let's say an infection from a UTI, or radiation therapy, cancer in the urethra itself, any kind of surgery or medical procedures that causes inflammation, or maybe even trauma from a kidney stone. That can all cause injury or infection, which is going to be your risk factors for urethral strictures. There's also problems with the prostate that can lead to urethral strictures as well. So infection and inflammation in the prostate, since it's so close to the ureters, don't be surprised if issues with the prostate causes a urethral stricture. As far as signs and symptoms go, what you're going to see with the patient that has urethral stricture, you'll see a decreased force in their stream. Now, depending on how the stricture is positioned in the ureter, you can also see a double stream. You might also see dribbling, which can hint at problems with urinary elimination, and maybe the patient is going to have a problem with urinary retention. Based on our signs and symptoms, what are some of the nursing diagnoses that we have? So we got knowledge deficit. Sometimes you just got to educate these patients because they don't know what's going on. They don't know why they're having urinary elimination problems with voiding, things like that. So that comes from the knowledge deficit. Now, the acute pain is usually related to bladder distension from impaired urinary elimination, or the inflammation and trauma itself that's causing the urethral stricture. The risk for excessive fluid volume, that can be related to the impaired urinary elimination as well, which causes urinary retention. For the labs and diagnostics, our gold standard imaging is going to be retrograde urethrogram. So this imaging study is all about using contrast to outline the lining of the urethra so that we can figure out where exactly the stricture is. Now, for more direct visualization and to confirm the diagnosis, we can use a cystoscopy. And while we're there, you can also use a cystoscopy to help treat the stricture. If we suspect any kind of bladder involvement, we can also do a voiding cystourethrogram, which evaluates the bladder by using contrast as well. Of course, before you do all of this, you want to do a physical assessment and assess the medical history for the patient, such as urinary frequency. Sometimes that can tell you a lot about what's happening. Now, to treat this, we can use dilation procedures where you can go in using a cystoscopy and just essentially dilate the urethra. A urethrotomy can be used to cut an opening in the urethral stricture itself to allow for a smoother flow of urine and help relieve any kind of obstruction. And of course, if the stricture is caused by a bacterial infection, we can use antibiotics to help treat it. These antibiotics can help the inflammation go down and hopefully treat any kind of obstruction that's there. So what are some of our nursing considerations? For pre and post-op care, we have to make sure that the patient can void. So how do we do that exactly? We got to monitor their INOs. We got to assess for any bladder distension. If it's caused by trauma, we got to see the characteristics of the urine itself. We got to assess for any kind of drainage, any kind of inflammation, redness, swelling. Overall, our main goal is to make sure that their urinary elimination doesn't get more severe. Now, erectile dysfunction, or ED, is another acquired disorder, and this most often is caused by something vascular. And this vascular issue is what causes the inability to maintain an erection. Now, in your patho class, you'll learn that there's two types of ED. Primary ED is usually something that's developed early on. Secondary ED is something that's secondary to a disease process. That can be anything from high cholesterol, smoking, plaque buildup, to trauma and infection. It can even be due to medications. So some of the risk factors for this is going to be hypertension, smoking, high cholesterol, depression, diuretics, alcohol, and a slew of other medications like ADHD meds. For erectile dysfunction, all you'll really see is the inability to maintain or have an erection. Now, because this is such a sensitive and personal issue, this can lead to anxiety and depression from the sexual dysfunction that they have. Now, regardless of what we think is causing the erectile dysfunction, we always want to make sure we get an accurate sexual history as well as a physical assessment. Then we can move on to a neurological exam or get blood tests like a CBC or a CMP. From there, we can see if they have a cholesterol problem, if they're anemic. Now, here's the medical treatment for this. So sildenafil and tadalafil, this is your PDE5 inhibitors, which is your phosphodiesterase enzyme inhibitor. One thing you should remember is that sildenafil and tadalafil, they both still need sexual stimulation when a patient is on these medications. You don't just take these medications and boom, you have an erection. You still have to have sexual stimulation. Now, the difference between sildenafil and tadalafil is that tadalafil is something that is pretty much all day. It lasts from 24 to 36 hours in your system. A lot of patients like this because you take it once in the morning and you don't have to worry about it throughout the rest of the day. All you need is sexual stimulation and then boom, it's working. Now, for sildenafil, sildenafil, this is going to be your shorter acting drug. The onset of sildenafil is going to be 1 to 2 hours, and it can last all the way up from 3 to 4 hours. Now, if these medications don't work, we can take a look at surgical options. Now, there's 2 types of procedures that we can do: inflatable or malleable. Either way, both of these procedures involve removing penile tissue, which causes a permanent alteration in the penis. So there's no going back. Once you have an inflatable or a malleable penile implant, you can take out the implant, but there's permanent damage to the penile tissue already. Now, the difference between inflatable and malleable is that malleable, there's flexible rods in the penis that you can bend and structure, while an inflatable implant is something that uses a pump and usually inserted into the scrotum that essentially inflates the penis and mimics an erection. Air is gradually released and the penis goes back to being flaccid over time. Remember that these are drastic options to use if the sildenafil or tadalafil doesn't work. Now, some of the nursing considerations that we need to think about is that we can't have the patient taking any nitrates. So if the patient has a heart condition and they're taking nitroglycerin, this is a contraindication to taking sildenafil or tadalafil. This can cause a massive drop in blood pressure, which can lead to other complications. We also have to educate our patient on reporting priapism, which is essentially an abnormally prolonged and often painful erection. This often won't be relieved by ejaculation or orgasms. Over time, a prolonged erection can cause permanent damage or permanent scarring to the penis. And again, sexual stimulation is required if you're taking sildenafil or tadalafil. Now let's get into neoplastic disorders. First up, you have testicular cancer. So this is going to be common in young men ages 15 to 35. It's often curable if we can find it early, but it can also spread early if not treated soon. The cancer can spread through the lymphatic system or the vascular system. Some of the risk factors include undescended testes, also called cryptorchidism, and if you have a family history of it. The highest incidence is going to be your non-Hispanic white men. The exact reason is unknown, but it's likely just related to genetic susceptibility, environmental exposures, and differences in testicular development. So overall, young white males have the highest incidence, but any male can develop it. Early detection is going to be key since it is curable, with cure rates over 95% if detected early. So as you can see here, some of the symptoms include enlargement or tenderness of breast tissue whenever it metastasizes. You might also see some back pain or discomfort in the testicle itself. You can see swelling, lumps, a dull ache in the lower belly, and just an overall feeling of heaviness in the scrotum. One of the common places for metastasis is going to be the lungs, so we want to make sure we assess for any kind of breathing dysfunction. Of course, this is another sensitive and personal issue, so a lot of anxiety and maybe some depression can happen. And since this is a cancer, you can have imbalanced nutrition and maybe even imbalances in your blood count. And if someone has testicular cancer and has a lot of pain and swelling, that can cause sexual dysfunction as well. To help diagnosis, we can use tumor markers, chest x-ray if it metastasized to the lungs, or use an ultrasound for the scrotum. There's different medical treatments we can do, such as an orchiectomy, chemotherapy, or radiation. Orchiectomy is essentially removing one or both of the testes. As for the nursing considerations, we just make sure that they follow up with their oncologist or PCP and provide resources if they need psychological or social support. You also want to do counseling because this can affect fertility. Now moving on up to prostate cancer. So with prostate cancer, this is going to be most common in older men. Early on, this is usually asymptomatic, and as the tumor progresses, you'll start to see symptoms. Even more so, as someone ages, the prostate gradually enlarges, so you can be in a situation where the tumor and the prostate are both enlarging. And as you can see here, it can be unilateral, depending on if it metastasizes to the other side of the prostate. Some of the risk factors include age, so we know that men over the age of 50, they're going to be at highest risk. Other risk factors include a family history of it. As far as ethnic origin, black men, especially those of African or Caribbean descent, is going to be at highest risk. Death rates are more than 2 times higher for African Americans than Caucasians. Other than that, a diet high in animal fat, being sedentary, and being exposed to chemicals can all lead to being at risk for prostate cancer. Now, some of the signs and symptoms you'll see are similar to having a urethral stricture, such as a urinary obstruction. You could also have swelling and pain and inflammation. You can have hematuria depending on how much damage the cancer is causing. You might see painful ejaculation and, of course, sexual dysfunction. Since this can cause a urinary obstruction, one of the nursing diagnoses is going to be urinary retention, of course. You can see acute pain and impaired mobility. So you need to center your interventions around these related diagnoses. As I've said before, if you suspect anything that's going on with the prostate, you can get a PSA level, which most of the time is going to be elevated, but it's not diagnostic of the condition. It just tells you that there's prostate involvement. You can also do a digital rectal exam. If you want to get a tissue sample, you can do a transrectal ultrasound biopsy, and you can also do a bone scan, depending on how severe the metastasis is and if it reached the bone. As far as medical treatment goes, sometimes watchful waiting is going to be a recommendation. Now, why is that? It's because many prostate cancers grow very slow. A large number of men, especially older men, will die with prostate cancer, not usually because of it. So just know that most prostate cancers are low grade, and it can take years to cause symptoms or spread. And since this affects mostly the older population, sometimes the treatment side effects can be significant and the risks outweigh the benefits. Surgery and radiation, it can cause urinary incontinence, erectile dysfunction, and bowel dysfunction. Typically, if life expectancy is like less than 10 years, then watchful waiting is going to be the recommendation. And the focus is going to be on quality of life. So no repeated biopsies, less frequent monitoring, and we treat it only if symptoms develop. If recommended, we can do a prostatectomy. We can just remove the prostate itself. We can of course do chemo and or radiation if the patient can tolerate it. And we can also do androgen deprivation therapy, or ADT, which helps reduce the testosterone in the body and slows down the growth of the prostate. As far as nursing considerations go, we have to make sure we know how to set up and monitor a CBI, or continuous bladder irrigation. You'll also have risk of impotence or erectile dysfunction, so we've got to make sure we know how to educate and use appropriate therapeutic communication with our patients. If the patient has surgery, of course we want to monitor for any kind of hemorrhage post-op, and we can educate our patient with hormonal strategies such as the androgen deprivation therapy. Now that's pretty much it for the rest of Unit 8. So if you want to take a look at this case study, which is at the end of the PowerPoint, this gives you the answers to the risk factors for erectile dysfunction, and you also have practice questions you can do. Alright guys, thank you so much. See you soon.